work in Amsterdam, the Netherlands. I have a background in public health and epidemiology, and today we'll be talking about social and physical environments and how they influence health and how we can use these environments to promote public health. So just to start off with saying that I don't think I have any conflicts of interest. I'm currently funded by a Dutch independent government research organization, and previously I've been funded by the European Commission. So I'd like to start off by telling a little bit about my own physical and social environments. So this is Rotterdam, or a simplified version in Rotterdam. But for those who've been there, you may recognize the skyline. It's a really nice city. I love living there. It's a little bit gray, but I cycle everywhere. I cycle to the shops, to the station, to my friends and family, because that is really easy. There are cycle lanes everywhere, and when there are no cycle lanes, it is still very safe because the cars are really careful around cyclists. I actually do not have a car. I don't really need it. I can go everywhere in the Netherlands by using public transportation, and it's really quite expensive to park a car in Rotterdam, so not really attractive to have one. Having a PhD, I think I can say that I have a quite high educational attainment, and these individual resources that I have gained from having a high education really have helped me navigate through life, I would say, and also through the environment that I live in. I can really use my own personal resources to make the most of what the city is offering me in terms of finding shops that I want to go to, or finding the recreational facilities that are available. So I benefit quite a lot from my education as well. I like horse riding, and luckily there is a nice park in Rotterdam where there's a horse riding center, and I go there 5 days a week. It's nice and green, so I spend a lot of time outdoors while also living in the city. So that's really very nice. And of course, my social environment is also very important to me. I have my friends and family living in Rotterdam. And if they're not living in Rotterdam, it's really easy for me to get to them by cycling or using public transportation. And obviously, you know, with modern technology, using WhatsApp and calling, etc., it's even more easy. Sometimes I run, but only to catch the train. Now I'm in Wellington. When I arrived here, even in winter, I felt it's so green, and it's so nice to walk around here and being outside in a lot of green area in the city. I've tried cycling. I find it quite hard. There are not that many dedicated bicycle lanes, and the buses pass really close. So I thought I would just walk in Wellington, or rather hike, because there are hills here, which we don't have in the Netherlands. But it's quite nice. I changed my routine, so I walk here in Wellington rather than cycle. And I'm sure there are horses in Wellington. I haven't found them. I don't have the time to go horse riding, unfortunately, but I think that would be very beautiful here as well. And of course, I have a social network here as well. Colleagues and friends that I enjoy the company of. And as I said before, it's really easy to keep in touch with friends and family in Europe as well through modern technologies. And then one more picture before we go off onto the research and evidence. And this is the cover of my PhD thesis, which was on obesogenic environments, really illustrating that the environment can make it much more difficult for individuals to be healthy and to maintain a healthy lifestyle. If you try to push a rock up onto a hill, and that hill is really very steep, the environment is really hindering you in achieving a healthy lifestyle and health in general. That is much more difficult than when, you know, the environment is helping you, when it's actually much more flat. So this is all anecdotal, and I think we can all relate to the fact that social and physical environments are important for our mental and physical health. But let's see what is out there in the evidence base. So before we head off, maybe some terminology and theory to make sure that we're all on the same page. I have a background in public health and epidemiology, and we also often use these socio-ecological models, or onion models or bubble models to show the different layers of influence, determinants that influence health. So this ranges from individual determinants such as genetics and sex, all the way up to macro level environmental factors such as international trade agreements and national laws and policies. And today we'll be focusing a little bit more on that meso level, so community or neighborhood environments and the social and physical aspects of those. So focusing on the out-of-home environments, sorry, Philippa. Housing is also very important. Today we'll focus on kind of the meso level. And I'll show you some examples of evidence on how the social and physical neighborhood environments influence health outcomes. This is an example from the UK showing the relation between area level deprivation and life expectancy in the blue bars and healthy life expectancy in the orange bars, showing quite clearly the gradient of life expectancy and healthy life expectancy across deciles of deprivation in the UK. So not only are people living in wealthier areas have a higher life expectancy, but also a much higher healthy life expectancy. And this is quite a universal graph in the sense that you can use this graph for other countries and for other health outcomes. Socioeconomic gradients across different areas are quite clear. And some of the pathways that have been put forward for how neighborhood deprivation can actually lead to worse health outcomes are a number of causal paths, including behavioral, psychosocial, and material factors that may explain these associations, such as a higher prevalence of smoking and alcohol use in more deprived areas, a lack of social support or feelings of social and crime safety, but also deprived areas may have less access to facilities, healthcare facilities, but also recreational facilities, for example, and maybe less aesthetically nice and less green, having worse housing conditions. But of course, a part of this association between area level deprivation and health outcomes may also be explained by selection effects, such as those with poorer health tend to move to areas that are less advantaged. This is an example from a European study where we linked aspects of neighborhood social capital to the odds of obesity, showing that both having stronger social networks in the neighborhood and higher levels of social cohesion were associated with lower odds of obesity. And some of the pathways that could explain this association is through informal control or normalization of healthier behaviors, collective efficacy, and the exchange of social support and role modeling. But I think it's quite important to remember that this can work both ways. So you can have role models that are very healthy, but also role models that are unhealthy. So if you have a community where people tend to have unhealthier lifestyles, then this may also help actually to spread obesity in a negative way. And that's quite nicely shown in this famous study by Christakis et al., who showed the spread of obesity almost like an infectious disease through social networks. And in the figure, you can quite clearly see that some persons in a social network are more important for spreading obesity than others. So having mutual friends with obesity, but also spouses, siblings, and especially same-sex siblings who have obesity increase your own risk of becoming obese over time. And this is an example from my colleagues in Amsterdam who used 8 Dutch cohort studies to link several neighborhood factors to the prevalence and severity of depression. And I've just highlighted the 2 social environmental factors that they investigated. So in figure B, you can see the relation between area level socioeconomic status and the prevalence and severity of depression, and in figure G, the area level safety. And you can quite clearly see that in areas where in higher socioeconomically, in areas with higher socioeconomic status and better safety, people had a lower prevalence and lower severity of depression. And this is again some results from a European study where we linked neighborhood environmental factors to how happy people are. And happiness is obviously quite strongly related to health, but happiness on itself is also quite an important marker of population well-being. And we looked at several objectively measured environmental factors. So we did a field audit going through these neighborhoods and having a checklist of what was present and what was the condition of the pavement, etc. And we also asked people about their perceptions of their neighborhoods. And we found that living in aesthetically nicer neighborhoods and neighborhoods with more water and green spaces as measured objectively was associated with being more happy. But when we looked at these subjective measures, we found that also safety and the functionality of the neighborhood, so how many destinations are there enough pavements, etc., was associated with more feelings of happiness. And I think this quite clearly shows that we need to take into account both objectively measured environments and people's perceptions about them, because we may think that, for example, we have improved safety objectively in a neighborhood, but if individuals don't perceive their neighborhood to be safer, they will not benefit from their environment. And in this study, also from this European study, where we showed the mismatch between objective and subjective measures, in some cases, there is really a very big mismatch. For example, people perceive that there are no food outlets in their neighborhood at all, while there are food outlets around them. So I think addressing this mismatch is also potentially quite important. So when we think about the pathways that lead from neighborhood or urban environments to mental health, well, first of all, I need to say that the evidence for these associations is still quite weak and inconsistent. I think much more studies need to be done about the influence of our living environments on mental health outcomes. I think this is a really important topic. But some of the pathways that have been put forward are that, for example, green spaces, but also neighborhoods with a high social cohesion can help with the restoration from stress and fatigue. Neighborhoods can help in having a good social support network. Neighborhoods can have an influence on mental health through getting insufficient daylight. Noise and air pollution have been linked to mental health outcomes, and also feelings of safety in the neighborhood. And I think these are factors that we could address through working on neighborhood and environmental interventions. So the evidence on environmental factors related to physical health are numerous. So a lot of reviews have been done on how environmental factors relate to obesity, type 2 diabetes, cardiovascular health outcomes. And they all conclude roughly the same, and that is there are a lot of studies, but the evidence is still quite heterogeneous. We find a lot of inconsistent associations. Some of the factors that have been quite consistently associated with these health outcomes are urban sprawl. So in more sprawling areas, there are higher rates of obesity, type 2 diabetes, and cardiovascular diseases. And neighborhood walkability has quite consistently been associated with lower risk of obesity, type 2 diabetes, and cardiovascular diseases. But based on these reviews, I think these showed quite clearly that more research needs to be done to better understand how environmental factors influence these health outcomes. So I'll just show you some of the examples of studies that we've done since then. So this is a study on objective measures and perceived measures of the built environment related to cycling for transport. And here we found quite consistently using both objective data and people's perceptions that a low maximum traffic speed was associated with more cycling. So in areas where the maximum traffic speed was, for example, 30 kilometers an hour, people were much more likely to cycle for transportation. And also the availability of bicycle lanes and the perception of better street connectivity, so having more routes to choose from on your bicycle, was quite consistently associated with cycling for transport. Then we also found some odd associations at first glance, seeing that having more litter in the streets and more parked cars on the road and less traffic calming devices such as zebra paths or traffic lights or speed bumps was also associated with more cycling. But going back to the data, we realized that some of the very quiet areas with very few cars were actually those areas with a lot of parked cars on the road and less traffic calming devices. So they may be areas where these devices are just not necessary. And then we also found that if people perceived the air to be more polluted and areas not to be pleasant for walking or cycling, that they cycled more for transportation. And thinking about that, this may be explained by, well, people may want to have a very nice area to cycle in if they do that for leisure. But if they do cycling for transportation, they probably have a specific destination in mind. For example, they do their grocery shopping or they go to work. And this is often in quite a densely populated area with a lot of destinations and maybe also a lot of traffic that causes air pollution. And maybe these areas are not so nice or pleasant to walk or cycle in, but it's actually quite a functional environment for cycling if you think about cycling for transportation. And again, I think having these insights on both objective measures and subjective measures of the environment is quite insightful. This is a study from my colleague Maartje Poelman at the Utrecht University, showing how the food environment is associated with cardiovascular diseases. And she showed that for the Dutch context, a higher fast food outlet density was associated with an increased incidence of cardiovascular heart disease and coronary heart disease. And my PhD student, Gabi Matthias de Pino, did this work on how the food environment has changed over time in the Netherlands. So these are the trends of the number of food outlets adjusted for the population growth over time between 2014 and 2004 and 2018. You can quite clearly see the enormous increase in food delivery outlets over time. That's the green line at the top. Also, restaurants, the blue line, have increased. Convenience stores have increased with a little dip around 2011. And local shops, the blue bar at the bottom, those are bakeries, butchers, greengrocers, more specialty shops. They have decreased over time. And not that much was going on for fast food restaurants and supermarkets. Not that much change over time. But I'll show you in a minute some examples of where we really need to dig a little bit deeper to get a sense of what is going on in the literature and some of the methodological explanations for inconsistent results in the literature. Because when we split these analyses of trends in food environment over time by area level socioeconomic status, we actually saw for the fast food restaurants and supermarkets that there was a difference between high and low SES neighborhoods, such that in the high SES neighborhoods, the number of fast food outlets and supermarkets decreased over time, while it slightly increased in the lowest socioeconomic status neighborhoods. And these trends are all significant, as well as the interaction by area level SES. And if you don't see these trends stratified by socioeconomic status, you may come to completely different conclusions about what is happening in the food environment. So yeah, I think stratifying by area level and deprivation may be quite important when thinking about the food environment. And we saw a similar thing when looking at the interaction between having access to supermarkets in the UK and educational attainment. And in this graph, you can see quite clearly that both living farther away from the nearest supermarket and also having a lower educational attainment was associated with a higher odds of being obese. But the combination of those two, so people living in an area with lower access to supermarkets and having a low educational attainment, had almost 4 times the odds of being obese compared to individuals having a high education and living closer to the nearest supermarket. And this is again an example where it's a little bit more nuanced than what you would think in the first instance. So this is work from Jolanda Maas from the Netherlands, who's doing a lot of work on green spaces. And in this paper, they showed that in general, green space, having more green space was associated with more feelings of social safety in the city, but actually not in very strongly urban areas. In those areas, having more green space was associated with less social safety. So the context in which this is studied is really quite important. So after showing some of these examples, we may wonder, so what is the potential for public health? there have been quite a lot of studies on how environmental factors influence our health outcomes, both mental and physical health. But what should we take into account thinking of what we can do in terms of policies and interventions? I think it's good to remember that there are a lot of benefits of environmental interventions, and the most prominent benefit may be that environmental interventions may help in achieving better lifestyle and better health without requiring a lot of individual agency. You don't have to rely on people's own cognitive and material resources to change their health for the good, because the environment could really help them making those changes without using those personal resources. So environmental interventions are really much more likely to reach vulnerable populations than individual level interventions. And I think also when thinking of environmental interventions, we could create a synergy between health benefits, but also environmental sustainability benefits, all at the same time, because the environment is influencing so much more than just health outcomes. And this potential may also result in more interest from other sectors than the health sector, if you can combine those interests of different sectors. But I do think it's important to take into account context specificity. I've given you some examples in this presentation from studies from mostly Europe, but Europe and New Zealand are very different, and even between Europe there are large differences in the environment. And this is just a simple graph of one indicator, population density, to show major differences between cities across the globe. So in Amsterdam, on average, there is a population density of more than 5,000 inhabitants per square kilometer, while in Wellington, this is approximately 750. And just the basic characteristics of these environments may have a big influence on the associations that you study and actually the associations that you observe. Because there may be a hierarchy of environmental factors that influence health outcomes. And for example, in Amsterdam, where there are already a lot of cycle lanes and people cycle everywhere, the explanatory value or the benefits of having more cycle lanes may be almost zero. And if you then study the benefit of cycle lanes, you may conclude, well, you know, doesn't really make use to install more cycle lanes. But in a completely different context where the level of cycle lanes is much lower, then cycle lanes, the benefit of cycle lanes is much, much bigger. So I think it's quite important to take this into account. And as an example, we did a study to see the association between neighborhood level drivability and the amount of minutes people spent in their car. And we saw within this European study quite big differences between, for example, the UK and the Netherlands. So environmental factors related to drivability were much stronger related to car driving in the UK than in the Netherlands. In these studies, I think it's also really important to take into account socioeconomic inequalities. And in a lot of the reviews that I also showed earlier, a lot of the primary studies that were included did not take into account any of these potential differences between high and low socioeconomic groups. And the environment may really have a very different influence on these subgroups. So if we have to think about policy options based on the studies that are out there, and most observational studies having not taken into account these inequalities, modeling studies may really help us to hypothesize about how these policies may impact different subgroups in a different way. And these are just two examples of modeling studies, and the one below is a study that I did 6 years ago with Philippa to see what environmental changes would help people to be more likely to actively commute to work without widening inequalities in active commuting. Because we want to use these environmental interventions ideally also to narrow socioeconomic inequalities. And I think it's quite important to assess the potential of those interventions for narrowing these inequalities before we actually start implementing them in real life. And when thinking of interventions, I think we should really consider very consciously what do we want to achieve, what people need to benefit most from these environmental interventions. Also, although I've shown quite a lot of studies that focused on one specific factor, Environmental factors definitely do not operate in isolation. In areas where there's a lot of green space, there is also maybe a lot of food outlets and a lot of other facilities. And it's quite difficult in these observational studies to pull these factors apart. And also when thinking of policies, we should think about whole neighborhoods or whole areas to target and not just focus on one silver bullet to solve public health problems, but really take into account a holistic approach. And then at the bottom, as just a reference to study of Jody Honig, one of my PhD students, who looked at the interaction between social and physical environmental factors. And this also relates to the hypothesis that, for example, green space may not have the same meaning to different groups in the population. And for people who perceive their neighborhood to be safe, green space may actually be really beneficial for their health. But for people who perceive their neighborhood to be unsafe, they may not benefit from this green space at all. So this interaction between social and physical environmental factors should definitely also be taken into account. I think it's also important to realize that some of these associations that I've shown are not necessarily causal associations. Obviously, when thinking of environmental factors, it's really hard to do a randomized controlled trial. So a lot of the evidence is coming from observational studies. And there is some evidence showing that if you account for residential self-selection, that some of these associations are attenuated. And by residential self-selection, I mean people who, for example, really like running or cycling may choose a neighborhood to live in that accommodates these preferences. So that's a form of direct self-selection. What is actually more common is indirect self-selection on the basis of socioeconomic status. So with a certain income, you can only live in certain neighborhoods. And more disadvantaged neighborhoods may also have more disadvantaged physical and social environments. And this is especially important when thinking about neighborhood policies and neighborhood interventions, because you wouldn't want to renew a certain neighborhood and then with the consequence that the neighborhood is valued much more, housing prices are rising, and the original inhabitants actually have to move away from that neighborhood because they can no longer afford it. And the reference is actually from a Dutch example where they didn't find these selective residential mobility effects. But still, this can differ between different contexts. So it's definitely something to take into account. But we've talked quite a bit now on how complex it is, and there are all kinds of factors that influence health outcomes. But this complexity should not lead to inaction. We do have a pretty good feeling of what type of social and environmental factors contribute to public health. And we shouldn't let, for example, alcohol, gambling, food industries use the argument of complexity to not take any action. So this is an example study from Mark Pettigrew from the UK, showing that the arguments of complexity are now used against public health interventionists, arguing that the etiology of diseases is very complex. So there is not one individual product or one individual factor that we should target. And population health measures that focus one of these factors, they will definitely not be effective because it's just one factor in a complex system. But I think it's good to take into account this complexity, but I also think we're quite aware of what the opportunities are of improving social and physical environments. And we should go into action about it. That is the end of my talk. If you're interested in this topic, feel free to visit the website upstreamteam.nl. Upstream Team is an international network of policymakers and researchers that are interested in these upstream or environmental determinants of lifestyle and health outcomes. We'll share new articles that have come out on this topic, but also we can share vacancies. We can accommodate collaborations on research projects, and it's for free, so you can subscribe and also unsubscribe whenever you want. Are there any questions?
You did mention gambling in your last couple of screens. I'm very aware that gambling is in the lowest socioeconomic areas in New Zealand, and they often have the poorest transport facilities and infrastructure. So these two things could hugely influence the mental health of the people in those areas. And when you add to that these these two issues are also in areas of high Māori and Pacifica populations, it has an even worse outcome on our expectations for their health. So have you got any comment? Are there similarities in Netherlands?
Yeah, I think in the Netherlands, the differences between deprived and wealthy areas are a little less big compared to New Zealand. So more deprived areas in the Netherlands are still have a really good access to healthcare facilities and recreational facilities and options for healthy foods. So I think the situation in the Netherlands is a bit different, but thinking about the situation in New Zealand, I do think that this situation warrants action. Definitely. And I was at the Ministry of Health this morning and we also discussed that there. So I think it's also on their radar. Yeah.
Yeah, thanks for those great insights. I really had a question about how governments organize their agencies to deliver on these kind of policies that cross so many different silos. And at the moment, New Zealand's having a review of its entire health sector, and it's bringing up the question of whether a Ministry of Health is able to reach out and influence all these policy sectors, or if we need another arrangement. And people are looking back more than 20 years to when we actually had a Public Health Commission that was separate from the Ministry of Health and had more of a mandate to work across sectors to implement this kind of healthy public policy.
Yeah.
Do you know any countries that have got this right? They've got a way of expanding the health mandate really across other agencies to get this more joined up response that I think this kind of evidence demands.
Yeah, I mean, I think it could be improved in many countries. I do think in the Netherlands and Scandinavia, this idea of health in all policies is quite active. So in the Ministry of Transportation, health is always a topic. And they will always have a person from the healthcare sector on their committees. So it's really an exchange between different sectors. I think this may be even better than just having a separate public health committee, because that's, suggesting that it is a separate topic, while it is really a really cross-domain topic. So I think, yeah, maybe having this health in all policies view, maybe that's happening in New Zealand as well, is really quite helpful at the Ministry of Economics, at the Ministry of Transportation, etc.
Consummately good talk, if I may say so, Joreintje, and you finished right on the dot at 1 o'clock.
Very Dutch.
Yes, very Dutch, and the speculum were lovely too. I think that what I took out of your talk and the discussions with you is about the nuanced results and being very careful about what associations and causations and so forth. I mean, actually, in terms of New Zealand, Karen Witten's work has shown, when they did a sort of earlier version of looking at resources, that inner city areas and the low-income areas are, in many cases, depending on where they were set up, are actually got lots of resources and lots of green space. It's the kind of post-war, unplanned communities which are very, the East Porirua and so forth, those areas, or South Auckland, which were very constrained in terms of other amenities, and it's taken 50 years to try and reverse that, and there's really only just big resources being put in again now. So we're a funny mixture. I mean, in some cases there's very mixed communities, and in other cases, recently they're much more differentiated. So that makes it more complicated even again, really, in terms of where people of low income are. And Wellington is very different from Auckland.
I mean, I do think that the general message would be that transportation is so important. I think New Zealand would benefit a lot from having better public transportation connections between areas and also to the smaller areas. I think Wellington has really good connections, but could be better maybe, but yeah, quite good. But compared to, for example, in the South Island, where people really need a car, and I think having this transportation network will really help people and access more healthcare facilities and benefit from their environments a bit more.
So a question from online, the team at the Cancer Society wanted to know, what is your view on the opportunities provided by New Zealand's wellbeing focused budget?
So I must admit, I don't know the details of that. Obviously, socioeconomic factors are so incredibly important for health outcomes. So I always have this discussion with colleagues. You know, if you had the choice to make environments healthier or eradicate poverty, you know, what would you choose and what would have the biggest impact on public health? And obviously, if we would be able to, you know, get rid of poverty, that would have a massive influence on the health of our population. So that is definitely a very good focus point that will contribute a lot to public health in New Zealand. I won't be able to go into the details of that Wellbeing Act, sorry.
To find a way to articulate this. So I get that there's policy, then there's people that deliver the policy, then there's the people that receive what the policy is meant to achieve. So have you come across any ways that the people who deliver the policy to the people who receive it, have you seen any ways that have been successful where the receivers understand what's happening in order to be able to help the changes be made? Because there's so many generational things that help the unconsciousness around all of the well-being and the healthy movements and things like that. And I get how the environmental factors help and social economic factors and things like that. But you also mentioned that there are groups of people, like different groups of people, know different things, are based in different beliefs and things like that. So have you seen any examples of successful ways of getting the understanding to happen so that more change can happen? Because it's obviously not just up to like government environments to make things happen. People have to make the change as well, but a lot of people don't understand that. So have you seen anything like that?
Yeah, so yeah, really good question. There have been a number of projects in the Netherlands on making neighborhood environments healthier. And one of the starting points from these projects were, well, from the point of the interventionists, we wanted to, improve health outcomes. For example, focus on obesity or on mental health outcomes. But they decided to go into these communities without expressing their own interests and asking, what would be your preferences? How do you want to change your life? What would be good for you? And sometimes those are very different topics that have nothing to do with health, but then try to find this common ground that is both serving health outcomes and, sometimes it's to do with people wanting to have, better job opportunities, for example. And I think in a lot of instances, those types of environmental interventions can help serve multiple goals. And I think trying to find that link between communities' preferences and also taking into account the benefits for public health is really quite helpful, and be clear about it. you know, also be clear about your own interest as an interventionist. But also in many ways, our environment has changed quite a lot over the past, and people like people have not been consulted about that. Like our environments have changed over time, and we have just adapted ourselves to those environments. So in a sense, I also think it's quite all right to change some of those environments back to healthier environments without actively consulting a lot of different groups of people, because we just know that it's better for health. But I think in some instances where it's, for example, very important to have culturally appropriate changes, then such an approach to find that common ground on the interests of the community and interests of the public health interventionist could work. And yeah, those examples in the Netherlands, they work quite well, trying to find that balance. May take a little bit more time than usual projects, but in the end, I think it's worth it because you've engaged the community with those decisions.
In New Zealand, we have one of the most beautiful environments, and we're very lucky because we have good wind to keep our air pure. But we also have a very high rate of suicide. And so how do you reconcile those two things, the beautiful environment, and up until recently, it hasn't been so obvious how spoiled it has been, and the suicide rate?
I think we really need to acknowledge that it's not just our social and physical environments at the city or neighborhood level that influence our mental and physical health outcomes. And I think there's quite a bit of literature showing that suicide rates are also connected to bigger trends in time related to, for example, inequalities in society or welfare of the whole nation, economic trends over time. And obviously also individual circumstances play a big role in that. So I think we should also be careful in not being over optimistic about what we can do through neighborhood or city environments. We won't be able to solve everything, all the public health problems. So yeah, I think it's good to acknowledge that, and that we shouldn't only look at those environments, but also think a little bit bigger and do think about our trade agreements and national laws and social welfare systems and how those bigger factors influence our population's health. Yeah, that's a good point.
Thank you so much for sharing your thoughts with us today. Joreintje's around this afternoon if other people would like to spend a little bit of time with her. So if you do, just pop down after we close and make a time with her. And it's just up to me now to say thank you so much for coming back to see us again and for sharing with us your wisdom and knowledge. Thank you. Please join me.